Hello, Dr. Hodson. We've
Hello.
received questions from our women regarding hormone replacement therapy. And more specifically, are there any negative consequences to not taking HRT when menopausal at a youngish age? Please, could you outline any of the risks of taking HRT? Are there any options for HRT if you have had breast cancer? Please, can you recommend any non-medical therapies rather than standard HRT? Does your body ever get used to HRT? And if not, are there any different forms that can be tried if one isn't effective? And finally, can you take HRT if you have had a BRCA positive breast cancer?
There's a lot to cover there. Right, so if I try and sort of divide it down. So HRT just stands for hormone replacement therapy. So we look at the estrogen, the progesterone. Very often we look at testosterone, and then the fourth very important one, as I discussed earlier, is the localized vaginal estrogen. So over the years, the HRT, just to give us sort of a brief history of it, lots and lots of women were up and running and doing very, very well on HRT until a study came out about 18 years ago called the WHI. Now, from then, thousands of women were taken off their HRT, and that legacy has stayed with us for all of these years. That study there were big problems with that study. There's a lot of good information that came out from that study, but there were also big flaws in the study. It should never have been released because the scientists hadn't all ticked it off as fit to go, and it got released to one of the big papers when it shouldn't have been. There's a little bit too much to go into detail, but there's a really good breakdown of that study and the flaws in it, again, on the Menopause Doctor website, if you search WHI and just going through. A lot of so HRT has changed over the years, and 20 years ago, it was the synthetic and very often made from, so Prem-RN was one of the commonest ones, and that was made from pregnant mare's urine, which is not particularly pleasant to think about. So it was synthetic, and it's moved on now. So the ones that we recommend is something called body identical. And what that means is it has the same molecular structure as your own hormones. And the data has indicated that it has a safer profile than the older synthetic ones. When you go back to that study, the numbers were actually quite tiny. And what happens a lot of the time when the press report on these studies is they use the statistics differently. So they will use something called relative risk instead of absolute risk. So an analogy that we often use is if you buy one lottery ticket, if you buy two lottery tickets instead of one lottery ticket, you've doubled your chances, which sounds like a lot. But when you actually look at it in something called absolute risk, you've got 2 in 3 million chance instead of 1 in 3 million chance. And this is where we get frustrated over and over again, because this is where the media will very often report it in that way. There's a brilliant, brilliant book. I'll just wave it here. Hopefully it will come the right way around. So if women really, really want to sort of dig down into this, it's called Estrogen Matters, and it's by a physician, an American physician called Avram Blooming. And what that does, it breaks down all of the studies to, again, just talk about statistics and how they are used. What we know is so again, with younger women, it's for the vast majority of them, it's really important that they have their hormones replaced. We do know that if you have a young menopause and you don't replace your hormones, you're at higher risk of osteoporosis, heart disease, and dementia. So for those women that can't have HRT, those are the 3 areas that you really want to focus on. It's speaking about depending on your treatment and whether you should be having bone density scans and looking at that in particular. And again, with the heart and dementia, it's looking at really sort of digging down into diet and exercise. A lot of women, so women who have had cancers, and again, we have to divide it into whether there has been a hormone element in the cancer tissue. So we know that lots of women, for example, things like thyroid cancer, bowel cancer, vulvovaginal cancer, cervical cancer do not have hormonal involvement. The leukemias, so the blood cancers, again, do not have hormonal involvement. So those women are generally absolutely fine to have HRT. When we look at breast cancer, it becomes ever so complicated, and you will often find that an oncologist will say one thing, a menopause specialist will say another thing, a GP will say another thing. And the reason for that is there isn't conclusive data. And for women and as medics, that can make us feel very, very uncomfortable, because there isn't a paper that will say, yes, HRT will increase your risk of breast cancer if you've had a estrogen positive breast cancer. There isn't a paper that will say, no, it doesn't. It's still arguing. We need a lot more research in this area. So the consensus at the moment, and again with breast cancers, this is why it has to be individualized treatment, and it's looking at, you have to look at the sort of the grade of the tumor, the involvement, the treatment, and how long post-treatment it was and the receptor status. So this is why it has to be a really careful discussion, and we do this a lot in the clinic, and it's looking again at symptoms and how much they're impacting on life. And in an ideal world, we would be speaking to oncologists. And again, it's so if we have women where they're coping well with their treatment, but they're looking at their future health protection, then HRT would not be recommended first line. If we have women that are saying to us that I just cannot live my life like this any longer, then again, we have to have a really careful discussion. And look, for some women, it can be changing their secondary treatment. So the treatments like the letrozole, the anastrozole, the tamoxifen, it's looking at what are those causing the symptoms, particularly and looking at whether or not the impact of stopping those. So it's as I say, it's not straightforward. I would definitely recommend that book again for really sort of digging down into it. We know, but again, we have to look at quality of life. There are non-HRT treatments that can be used for some of the symptoms. And so very often there are things, there's an antidepressant called venlafaxine that can be used to manage. It gets a little bit confusing because venlafaxine is generally used as an antidepressant. But we know that very often during menopause, because the mood changes are caused by lack of hormones, the classical antidepressants don't work very well with them. If you have a separate sort of a clinical depression, then the antidepressants may well work. So it's worth trialing. What they can work well for is the vasomotor symptoms, so things like the hot flushes and the night sweats. And I think it's definitely worth giving that a try, because again, if you can reduce those, you very often will get a better quality of sleep. And that again is key for mood and just day-to-day functioning. So again, we'd say try it for 3 months, because that's usually long enough to know whether it's going to work for you. There are some other medications, there's things called gabapentin and pregabalin that again can help with the vasomotor symptoms and can be started in low doses and titrated up. Those ones can cause quite problematic side effects with sedation. So again, and that can generally be done through your GP. And again, try and sort of tiny doses to start with and gradually wean up and see how you respond to it. There's an older, it was a bladder medication actually called oxybutynin that was designed for irritable bladder, and that again can help with hot flushes. I think with the herbal remedies, you have to be ever so careful, and I would always advise seeing a medical herbalist. They can be potent, they can interact with your treatment, and they're not without their side effects. So we know that some of them can cause elevated liver function. So it's not something to just whiz off to Holland and Barrett and pick off the shelves at will. I think it should be done very, very carefully. We know that, apart from that, sage can help with hot flushes, but a lot of things, so things like red clover are isoflavones and can also impact on estrogen. And if you're on anti-estrogen treatment, it's important that you don't use herbal remedies that could then change the estrogen levels. So again, they're not regulated, and you can get different doses in different brands. So it's something that I would say do very, very carefully with expert guidance. So when we look at HRT, and again, there isn't a one size fits all. So what we look at, we tend to stick to estrogen that's through the skin. So that's in the patches, the gels, or there's a spray. And the reason for that is it doesn't activate the clotting pathway. So this is another area where lots of women are told that they can't have HRT if they've had migraines or high blood pressure or are overweight or have risks of clotting. And estrogen through the skin doesn't activate the clotting pathway. It behaves very differently. We start off, so we're looking at the lowest dose that will control symptoms. So it's lots of adjusting and tweaking up until we get symptoms controlled. And again, some women won't absorb very well through the patches, so we will change to the gel and vice versa. And so we get, that's your bread and butter HRT. Women who still have a womb will need progesterone as well. And again, we would recommend the body identical progesterone. It's a newer formulation, and there's a French study that shows that there's no increased risk of breast cancer for the first 5 years of using it. What we know, and again, we'll have to take women with put the cancer diagnosis to one side for a second. We know that generally women under the age of 51 using HRT do not have any increased risk of breast cancer. So your clock sort of starts from 51. As I say, with women who've had cancer, it needs to be an individualized consultation because we need to look at the hormone status. If women have the BRCA gene, there are specific guidelines, and they will very often have risk-reducing surgery. And then it's important that they actually have HRT at least up until the age of 51. So there's good data regarding that. So just to take that confusion. Again, just going slightly aside, women with a family history of breast cancer, it needs to be a careful consultation with the family history clinic. For those women, they will have an increased baseline risk of breast cancer because of the family history, but HRT is not thought to increase that risk further. So you can see there's an awful lot of confusion out there. And I think I would say that the more you read around HRT, the safer it becomes. There's a lot that we don't know yet. And there's a lot in particular with breast cancer, because it's such a sort of complex thing with receptors and how they change and they can behave differently woman to woman. There's a lot that we don't know yet. And that's, again, it can be very unsettling for women and very unsettling for medics. And I think there's a lot more debate that we need to have, and definitely a lot more research. I think I'll just have a quick look at the questions and see whether we covered them all. So that was just going back to the, should you change your HRT after a while or stick with it? I think that's, again, it's just looking at symptom control, and very often, as I say, we often look at testosterone as well, because that can be the absolute icing on the cake to get sort of energy and your zip back. And again, just going back to the localized vaginal estrogen, because it can make a big, big difference to comfort. It is absolutely safe for the vast majority of women to use, and that's even women who've had a breast cancer.